All right. Hello, guys. So today I'll be talking to you about valvular heart disease and rheumatic valvular disease. So it's a very big topic, and therefore I'd suggest that you speed up this video according to your comfort, and let's get right on with it. So let's start. First of all, when you're answering this question, you have to answer what are valvular defects, why does it occur, what causes these defects. We talk about the different kind of abnormalities that can be seen, and also which valve is most commonly affected. It's more of a general knowledge kind of a question. All right, so let's get started from the beginning. So valvular defects is nothing but a defect in the structure of the valve. Therefore, there's a loss of integrity and also a loss of function in the valve. And this can be caused by stress stimuli. All right. Now, if you want to understand the different kinds of stress stimuli and why exactly these valvular defects occur, we can understand it by knowing that there are two main kinds of defects, stenosis and insufficiency of valves. Stenosis means there's a narrowing in the lumen or the in the opening of the valve, and insufficiency is where the valves are not able to close completely, and therefore, when any of these chambers are squeezing the blood to the next chamber, there's a backflow of the blood through those valves. All right. So um, when we talk about stenosis, we are mainly talking about um, pathological blood flow of blood in the forward direction. That is, for example, from the atrium to the ventricles, that's a forward direction, or from the ventricles to the aorta, left ventricle to the aorta, that's again a forward direction. And if I'm talking about the pathology related to insufficiency, I mean backflow of blood, which is we find pathological states, or we can identify pathologies based on the flow of the blood in the backward direction from the ventricle to the atrium, or from the aorta back into the ventricle, left ventricle. Now, what causes each of these situations? So, stenosis, the principle is that there'll be fibrosis of the valves, and this will lead to scarring, and ultimately, in a chronic situation, it leads to calcifications. All right. So the valves can sort of get fused together, or they can be improper movement. There won't be a complete movement, and therefore they can stay closed for the majority part. Now, the causes of the stenosis can be aging, so degeneration leading to fibrosis and scarring, endocarditis, again, inflammation, fibrosis, scarring, and calcifications, other traumatic causes, which will again lead to inflammation and therefore scarring and calcifications, rheumatic heart disease, which is sort of it's a disease where there's inflammation of the valves, and that will again lead to the same situation. There can also be a congenital lesion. For example, in some cases, there can be bicuspid aortic valve instead of tricuspid, and in this situation, these valves are they have more work in terms of trying to keep the blood within the ventricle and trying to prevent any backflow. So when this happens, when there's a lot of work for the ventricle for the cusps to do, they can get degenerated quickly and they can undergo calcification. Carcinoid syndrome is where they can be, for example, they can be a tumor which can be secreting some growth factors which can stimulate the fibroblasts in the valves to increase their production of ECM. And in this process, it can lead to fibrosis of the valves and eventually calcification. Insufficiency. Now, for insufficiency, there can be four main reasons. Number one, something is preventing the valve from closing properly. Number two, the valve itself is damaged, therefore it can't close properly. Number three, the structures that assist the valves in opening and closing are damaged, and therefore they cannot close properly. Other causes can be these, and you can just try to memorize as much as possible. I would say try to remember tetralogy of Fallot and Marfan syndrome at least. As far as floppy mitral valve syndrome is concerned, we'll just get back to it later uh, through this Word document, so you don't have to worry about it. Now, what is something that would prevent it from closing properly? It could be some cardiac tumor like fibromas. If the valve has to be damaged, it could be because of some mechanical trauma. It could be from thrombi or indwelling catheters. It could be drug-induced damage. So there's a hypersensitivity type 3 reaction where immune complexes are going to get deposited onto the valves. That will create an inflammatory reaction, damage. Then finally, endocarditis, again to the inflammation pathway. All right. So, for the supporting structures to be damaged, there could be ischemia, endocarditis, trauma, or some hypertrophy or dilatation of the chambers, which would result ultimately in a change in the structure and the structural integrity of chorda tendineae, papillary muscles, and walls of ventricles. And this would obviously result in the valves not being held properly, and therefore they cannot open or close properly. Now, you can also, if you want to understand further about the etiology of valvular defects, you could divide it into congenital and acquired. Congenital example is the bicuspid aortic valve that I spoke about. Acquired could be due to, for example, any sort of inflammatory disease. It could also be because of aging. There can be degeneration of the valve, and it could become fibrosed, and it could become calcified as well. Now, for each of these valves, mitral, aortic, tricuspid, and pulmonary, you can see stenosis and insufficiency. Now, why or which valve is the most commonly targeted? Obviously, the valve that undergoes or that basically faces the highest amount of stress. So, in case of mitral valve, right, you have the left atrium, okay, where the blood can tend to stagnate, or you have the left ventricle, which squeezes the blood into the aorta with so much of pressure, and also, when this increased heart rate, the mitral valves have to keep opening and closing more frequently. And all of these things can, lead to degeneration of the mitral valve much more soon compared to the other valves. So, even in rheumatic heart disease, the order of the most to least affected is mitral, then comes aortic. That's the second valve that is facing the most stress, then tricuspid and pulmonary valves. Now, when we are trying to auscultate a patient, okay, and if we can sometimes find irregular heart sounds, these can signify or indicate a possible valvular defect. Now, these sounds are quite characteristic, okay? Certain defects can cause certain sounds to be heard through auscultation. So, when we are studying about valvular diseases and valvular defects, it's quite important to know the different kinds of sounds that we hear. However, since it's a very big topic, and also I'm not able to cover all of these things in one video, I would suggest that you learn more of this in pathophysiology, and also you can watch some other YouTube videos which can explain these murmurs and these other sounds in greater detail. But just to give you a basic idea, okay, murmurs are sounds that you get when the blood flow through the valves is turbulent. Okay, different valvular defects cause different kinds of sounds at different timings of the cardiac cycle. So we can go through it just in brief. For example, let's say in mitral stenosis. In the case of mitral stenosis, you have the mitral valve, which is very small now. It's not opening completely. Okay. So the left atrium has to squeeze the blood into the left ventricle with greater pressure. Okay. As a result, what happens is the left ventricle will which I mean, I'll actually speak more about this in the later parts of this document, but essentially it has to squeeze much more hard. Okay. And if you read this, see, initially the flow of the blood through these valves is slow because it's small. And then as the atrium squeezes and as the blood continues to exit into the ventricle, the flow becomes stronger, right? And then at the last moment, there's an atrial contraction that occurs, which squeezes the remaining amount of blood that is left in the atrium into the ventricle. So this sound that you get when this type of flow is happening, it starts low, then it is gradually heard stronger because of stronger flow, and then it becomes softer. Okay, because the left atrium is almost emptied. And then finally, when there's this atrial contraction that occurs, there's again a strong sound that is heard. So this is a diastolic rumble murmur. You can go through this document to understand the other kinds of murmurs, and you'll get a better idea of these. So you have murmurs that you can use to evaluate which valvular defect you have. You can also understand the four different kinds of heart sounds, and this is good for you to understand how exactly these different sounds can be like heard and when they can be heard. Again, you can go through it, and I think I've already explained this in the document itself. You can read through it. Um, and then you have apex beats. This is quite important, which I will cover right now. So, um, this is essentially when you hear the heart just being palpable at its apex, okay, as a tapping sound while auscultating, it is basically occurring because the ventricle is underfilled. Okay, so the ventricle does not need to squeeze too hard. At the same time, it doesn't squeeze very less. It's just somewhere in between. Okay, so there's just mild tapping that occurs, and this is tapping apex beat. When you have aortic stenosis, the left ventricle has to squeeze the blood, right, with a lot of strength, with a lot of force. Over time, there'll be left ventricular hypertrophy, okay? And also, because with time, more and more blood just continues to get pooled within the left ventricle because it's not going to exit the aorta, the time of contraction of the left ventricle becomes longer. Okay. And therefore, when you hear in aortic stenosis, when you auscultate, you can hear a sound that is very strong. Okay. And it's of a longer duration. It sort of feels like there's a sustained hitting of the apex of the heart towards the chest wall. And this is called as a heaving apex beat. Finally, in the case of aortic regurgitation, the left ventricle again is filled with a lot of blood, okay? And here there's no problem in sending out the blood into the aorta. However, there's a backflow of blood, okay, after sending some of the blood into the aorta. And therefore, in this case, the ventricle it does not contract for a very long time. And here the heart hits the chest wall quickly and also leaves it quickly. So this is a thrusting apex beat. Now, you also have some snaps, and this is just a conclusion of the different kinds of sounds that you can hear. Excuse me. Right. So now let's get to the actual, the main part of this answer. So we have got mitral stenosis, stenosis and insufficiency, right? So let's start with mitral stenosis. First of all, cause rheumatic heart disease, inflammation, fibrosis, calcification. Congenital could be the bicuspid aortic valve. Senile, again, degeneration, fibrosis, scarring. Carcinoid heart disease, increased activation of fibroblasts, fibrosis, scarring, calcification. Gutenberger syndrome is something that I think you can just try to remember. Not very important. Or maybe they might ask you, never know in pathology. You can just try your best to remember this. Now, we have the causes. Let's go for pathophysiology. So you have one has mitral stenosis. There's increased left atrium pressure because the left atrium cannot push all the blood into the ventricle. Over time, left atrium can undergo two things. Either it could undergo hypertrophy or it could undergo dilatation. When does this happen? So, typically, what happens is when there's a sudden increase in the volume of the left atrium, okay, it has to accommodate as much as possible. So, what can happen is there can be dilatation or hypertrophy, okay, and in this case, what can happen is, especially with dilatation, okay, there can be thrombosis. How does that happen? Well, there's dilatation of the left atrium, there's more blood. There is a good chance that not all parts of the left atrium will contract at the same force. Okay, some areas or in the space in the left atrium can have stagnation of the blood. This can predispose the blood to thrombosis. Okay, now can also be the case that when there's dilatation of the left atrium, okay, there can be new ectopic focal areas that can start um, having its own electrical activity and that can interfere with the electrical rhythm or the electrical conductance to the left atrium. When this happens, there could be ectopic foci of electric potentials being generated, right? And this can lead to atrial fibrillation. When there's a change in it, when there's atrial fibrillation, there can be re-entry mechanisms, etc., which can ultimately cause arrhythmias and irregular pulse. This can predispose again the blood to stagnation or through to a turbulent blood flow within the left atrium. This will lead to thrombus formation. The thrombi formed here is known as mural thrombi. Now, the thrombosis, right, will get formed, and with time, maybe the thrombus can break. There can be emboli. Basically, the moving thrombus is called emboli here. So the emboli can, from the left ventricle, it can go into the aorta, and from aorta, it can go into the brain. It can go into the rest of the parts of the body. It can go into the kidneys. So all of these can cause infarction of the organs. Okay. Another thing is because there is left atrium hypertrophy and there could also be stagnation of blood in the left atrial dilatation. What can happen is there can be increased pressure within the left atrium, which will propagate backwards into the lungs, and this can lead to increased pressure within the pulmonary vessels. Okay, so when this happens, there is a protective mechanism, okay, of pulmonary vasoconstriction. So there's increased pressure within the pulmonary vessels, and there's a protective mechanism of vasoconstriction that occurs, right? All of this can cause pulmonary hypertension. And until this vasoconstriction is capable of containing this increased volume of blood into the lungs, what can happen is there can be flow of the fluid from these vessels into the surrounding tissues because there's increased pressure or like increased hydrostatic pressure within the pulmonary vessels, and this can result in interstitial pulmonary edema. And if there's a continuation of this interstitial pulmonary edema, the fluid from the interstitial spaces will get into the alveolar spaces, which will then cause alveolar edema. Okay, so to remember this, just understand the flow of the pathophysiology over here. Then just know what thrombosis can do. It is infarction and pulmonary edema. In pulmonary edema, just think that, okay, logically it will first go into the interstitial space and then it will get into the alveolar space, okay? And then remember that there's a protective mechanism, and that's why there could be pulmonary hypertension as well. Now, all of these things, okay, this increased pressure within the pulmonary vasculature can again reflect back and can get into the right side of the heart. Here, now the right ventricle has to bear the brunt, okay, has to deal with this increased pressure. And what can happen is because of this huge pressure flowing backwards, okay, from the lungs, then to the pulmonary vessel, okay, um, sorry, yeah, pulmonary artery, okay, then it will go from the pulmonary artery into the to the right ventricle. The pulmonary valve can get damaged, and here there can be regurgitation, okay. Here you can hear Graham steel murmur. There can also be a tricuspid regurgitation because the fluid will then get into the right ventricle, okay? And then from the right ventricle, if this right ventricle gets completely filled, then there'll be backflow of blood to the right atrium, right? So that's why you can also have tricuspid regurgitation. So here you have mitral stenosis, okay? This can go backwards and can lead to regurgitation on the right side of the heart. So pulmonary valve and tricuspid valve regurgitation. Right. So the right ventricle can also undergo hypertrophy and dilatation. Now, how do you diagnose the mitral stenosis? So first of all, we do chest X-ray, ECG, labs, history for rheumatic heart disease incidence because rheumatic heart disease is the most common cause for for mitral stenosis, right? You can hear heart sounds and you can hear tapping apex beat that I just spoke about. You can hear opening snaps and murmurs. So again, you have to in order to understand these, you'll have to just go back to my document and you can also refer to other videos because otherwise it will be too much to cover in one question. As far as as if you ask me whether it's really important to answer this in your exam, for pathology, not so much, although they can ask, and you have to answer something in the diagnosis part of the question because in any pathology you always have to ask, you also always have to answer about the etiology, which is the causes, a little bit about the pathophysiology, and because valvular diseases here it's mainly like pathophysiology related, you can talk about this part, and then diagnosis just mention a little bit. Now, with regards to the macroscopic pathology, I'll just come to that all at once at the end. Now, mitral regurgitation, epidemiology, mainly in young women. Marfan syndrome predisposes young women to mitral regurgitation. The causes could be mitral valve prolapse, also known as a floppy mitral valve syndrome or Barlow syndrome. Essentially, the mitral valve becomes damaged, becomes weak, and there's this ballooning. So if you imagine the top of my hand to be the left atrium and the lower part over here to be the left ventricle. When the left ventricle squeezes the blood into the aorta, there can be a backflow, right? And because these mitral valves are weak because of various etiologies, they can sort of balloon like this into the left atrium. Okay, so that is mitral valve prolapse. And by doing this, by repeated ballooning, eventually they can become so weak that there can be regurgitation. Okay, so we have this, we have left ventricular dilatation. Again, changes in the architecture of the chamber can cause loss of the functioning of the supporting structures of the valves, and that can cause insufficiency. Okay, and the cause of LV dilatation over here could be left-sided heart failure, dilated cardiomyopathy. Again, typical inflammatory diseases. Papillary muscle rupture could also be because of myocardial infarction or left-sided heart failure, myocardial infarction, dilatation, etc. What's important over here that I would like to mention that you might have to remember for mitral regurgitation is aortic, the influence of aortic valves. So the way you remember the pathophysiology of these defects is you can just not only consider the damage that can be caused to the specific valve that you're speaking about, but also consider the damage that can be caused to the valves around it. Okay, so after mitral valve, you have the aortic valve if you go according to the forward flow of blood. So when there's a damage to the aortic valve, right, there can be a damage to the mitral valve over a period of time because there's a problem with the blood flow. When there's stenosis, there's increased pressure in the left ventricle, increased pressure in the left ventricle, gradually left ventricular dilatation, or it could also lead to increased backflow, forceful backflow to the mitral valve damage. Aortic regurgitation, here there'll be volume overload. Sorry, when there's pressure overload, there'll be hypertrophy of the left ventricle, and then later on it'll get into the left ventricular dilatation. And when there's volume overload, there can be left ventricular dilatation, and again there'll be a mitral regurgitation as a result of left ventricular dilatation. Yeah. So let's go for the pathophysiology of mitral regurgitation. So, if when there's in acute mitral regurgitation, right, there'll be severe pulmonary edema because there's flow of blood back into the left atrium and then again into the lungs. Uh, there can also be chronic mitral regurgitation where there'll be left atrial hypertrophy and dilatation. Okay, both of them will occur simultaneously. Then left ventricle will undergo dilatation because it becomes overloaded with blood, eventually becomes dilated and very big, and the whole heart becomes larger. And if you look at the complications, it can be thromboembolism. I would say if there's any sort of a turbulent blood flow, there's always a risk of thrombus formation. So that's how you remember this. Infective endocarditis, arrhythmias, sudden cardiac death. Because remember that endocarditis can be a cause of valvular defects, and at the same time, valvular defects can predispose these valves to inflammation and endocarditis. They can also be sudden cardiac death. Now, diagnosis again. Here you can look more into chest pain, palpitations, and dyspnea because of pulmonary edema. And others include the basic chest X-ray, ECG, trusting apex beat, important. Look into the murmurs and the opening snap into greater details. Next we go to aortic stenosis. Give me a break. Okay, right. So in aortic stenosis, epidemiology, typically greater than 60 years of age. So if there's a patient having some murmur that you think might be caused by aortic stenosis. If this patient is old, then that's most likely the case. And aortic stenosis is the most common valvular abnormality of all. I'm not sure why this Y is there, but okay. Now, causes. Again, you have the aortic valves, okay? Inflammatory causes can lead to fibrosis and scarring and calcifications, number one, which would mean rheumatic heart disease, right? Then congenital bicuspid aortic valve that I spoke to you about earlier, that can be the cause. And of course, old age related, so senile aortic stenosis caused by calcification. And finally, you can have dystrophic calcification caused due to wear and tear, also due to other pathological mechanisms that are running in the body, which can cause increased incidence of calcification on various tissues. Okay. Now, um, what's important to note is the difference between the calcification in dystrophic calcification and rheumatic heart disease. I think it's quite important. Just know about this. So, uh, RHD always starts on the mitral valve. Okay. Therefore, if you compare the calcification between these two and trying to figure out if this calcification is caused due to dystrophic or rheumatic heart disease, when there is a coexisting mitral stenosis, is most likely the case. However, uh, other thing is when there's a fusion of the commissures, okay, what can happen is again there can be mitral stenosis, but here this fusion may not be caused due to calcium masses on the cusps. Okay, they can just be as a result of inflammatory reaction. So over here, when there's a fusion of the commissures without calcium masses, it will again indicate rheumatic heart disease. In dystrophic calcification, you usually see nodular masses of calcium located haphazardly, and that's how you differentiate it. Now, the pathophysiology. So we're talking about aortic stenosis, so narrowing of the aorta, which means increased pressure in the left atrium due to outflow obstruction, leads to concentric left ventricular hypertrophy. Pressure overload will be there. There'll be decreased pressure in the aorta because when there's stenosis, not much blood is getting into the aorta. Okay. Now, here's what's happening. When not much blood is getting into the aorta, there will be lower blood pressure in the aorta. But there's so much of blood in the left ventricle because there's aortic stenosis and blood can't go out of the ventricle. Therefore, there's a huge difference between the pressures of the left ventricle and the aorta. This creates a transvalvular pressure gradient, which can be measured by echocardiography. Okay, when it's more than 60 Hg, then it's very important if you operate the patient. Now, what are the complications of aortic stenosis? So we know that the blood to get into the coronary arteries, okay, the coronary artery, the opening is located after the cusps, right, into the in the aorta. So uh, obviously, when there's lower pressure in the coronary arteries, okay, during diastole, that's when the valve is closed, and now you just the rest of the organs have to deal with whatever blood pressure is there in the aorta and in the larger arterial system. Here, there's lower pressure in the coronary arteries because lower pressure in the aorta. And this means there's lesser amount of blood getting into the myocardium. Okay, so now left ventricle has to deal with a lot of pressure. Okay, so the left ventricle has to contract forcefully, which means left ventricle needs more oxygen. But there's low pressure in the coronary arteries, so you have a high O2 demand, but the amount of O2 getting into the coronary arteries through blood and into the myocardium is low. So here it can result in ischemic heart disease. Now, when someone is exercising and if they have ischemia in the heart, so this increased myocardial need of oxygen versus the reduced pressure of the blood in the aorta can create such a huge valvular pressure gradient and also such a huge difference between what is required and what is being sent into the heart that there can be sudden cardiac death. Okay. Now, less lethal complications could be angina pectoris due to ischemia, syncope because of decreased cerebral perfusion, because obviously not much blood is getting into the brain now. Dyspnea because there'll be increased pressure in the lungs because increased pressure in the left ventricle eventually goes into the left atrium, and then if you trace it back, you're going back into the lungs. Arrhythmias definitely because of dilatation and probably hypertrophy. Microangiopathic hemolytic anemia because valve is damaged, RBCs try to go through it, and the two with so much of force, so they can undergo hemolysis because of like physical trauma. And obviously, this pulmonary edema can cause lung edema, which I think is the same thing. Anyways, diagnosis is again murmurs, heart sounds, ECG. The pulse is weak because there's low pressure in the aorta, and there's a long asymptomatic stage where the patient may not complain of anything. And this is because there can be a hypertrophic compensation. Then we go for the aortic regurgitation. So aortic regurgitation is where there's a backflow of blood from the aorta back into the left ventricle during diastole, obviously. So the cause of this could be a root dilatation caused by hypertension and aging, syphilis, aortic dissection. There can obviously be a valve damage or Reuters-Marfan syndrome. Now, the pathophysiology of this, sorry, is